in Istanbul this time on the 17th of May, a joint meeting between EOC and SO, and of course this will be important participation of persons from the MD Anderson as well as all the major leaders of the region to speak about all the aspects of hematology, not only oncological but also I would say benign hematology. And this is an event that we'd like to continue and to expand because it's important just to see what is the most recent, which are the most recent developments of the research in the field of hematology, and also to see what we can really translate in our common everyday clinical practice. This is what sometimes is difficult to be done, but it's needed if we want to improve the management of the hematological malignancies for a better survival of our hematological patients. So I will speak, the title was very, very vast, so I've decided to focus on some aspects. It was impossible in a short time to condense all the myeloproliferative diseases. I will present something which is prodromic to what Elmir will say after me, is that at the moment for the management of CML, we have at our disposition at least 7 different TKIs. One, the olverembatinib, is already available in China, not yet in Europe or in the United States or so on, but I'm sure that it will be approved soon. But what have we obtained with so many and different TKIs in CML therapy? We can see it from the data that we have collected in the Italian registry, in which more than 1,400 patients have been enrolled. And these patients were started by using imatinib or second-generation TKIs in approximately equal number, 1,700 or more with imatinib, 1,700 or more with second-generation TKIs. As you may see, however, the Italian hematologists prefer to use second-generation TKIs for the younger population, reserving imatinib for the patients above the age of 70. This is not perfect alignment, but this is the general rule. This means that these two cohorts cannot be easily compared because, of course, there is a huge gap in terms of age, which is 63 years for the imatinib-treated patients and 51 years, so a gap of 15 years between those who are treated with imatinib or second-generation TKIs. And however, the overall survival of the entire population is 88% after 5 years, so not so bad, therefore very good. But what is very important to notice is that indeed the CML-related death, so the deaths that can be due really to CML are only less than 1/5 of the total death, 16.5%. So a small percentage, whereas most of the patients are dying because of other causes. And you may see that the major cause of death is definitely progression. Progression can be to accelerated phase according to the old definition. Now it's changing, but I do not know. I would say that the propensity will be just to continue with the old definition of accelerated phase, because to change definition at the moment will create a lot of problem rather than solving problems, in particular the fact that some drugs in some countries are only allowed if the patient is defined as an accelerated phase and not if it's an advanced chronic phase. So this is a nomenclature problem. However, in accelerated phase, according to the definition, we have 14 cases. And you see that the overall survival, however, of these cases is quite good, because only 3 patients died once that they were in accelerated phase. The opposite is for the blastic phase. The blastic phase is still a problem, because out of 27 cases, we had 19 deaths. And I just heard yesterday that even in lymphoid blast crisis, even the best therapy that we have at the moment, hypercivat and so on, is not so effective in lymphoid blast crisis, which can be considered from the clinical point of view at least a different disease. And we still need, therefore, to provide very good therapies for advanced phases of the CML. If we see the difference in overall survival, of course, is higher for the patients treated with second generation with respect to those treated with imatinib, but this is due to the difference in age, because the progression, indeed, of the causes of death is approximately the same in both groups. So apparently in this group we have an advantage for the patients treated with imatinib, but this is not statistically significant because of the low number, indeed, of deaths CML related. But in the population, elderly population, the CML-related deaths represent less than 10% of the total deaths, whereas they are increasing in 37% of the CML-related for the patients in the younger age, so the age, and this means that one important aspect to consider for the patients who are treated or who are progressing is that most of the progression are occurring within the first 2 years from the start of the therapy and from diagnosis, therefore, and only 2 or 3 cases appear after the second and third year. So there is a sort of stabilization effect due to the TKI therapy on the patients, even if the patients has not achieved a optimal, we can say, molecular remission. However, is a survival that can be considered MMR in terms of survival, of course. I would say that the risk of progression of these cases is very, very low. So this is an important practical aspect that we will consider later on, and I would like to hear also your opinion about this. How can we identify the patients at risk of progression and death of CML-related death? By using the LTS score. You see that the patients who are in the low risk score, that fortunately enough they represent 2/3 of the entire population, have an overall survival which is very good, almost 96%, whereas those intermediate lower, less than 80, and 71 for the patients in the high-risk group. Unfortunately enough, those in the high-risk group are only representing 11–12% of the total population. Which are the causes of death if they are not dying of CML? Mainly of comorbidities. So cardiovascular comorbidity first, but also second neoplasia, different neoplasias, infections, and so on. So this means that apart curing CML, we have to take care also of the comorbidities which are associated with CML, because it's more likely that the patient is dying because of other causes rather than of CML. And this is an important aspect to be considered in our clinical practice. So the question now is becoming, should we try to improve our first-line therapy by having other TKIs, or should we concentrate simply on those who have, I would say, specific subgroup of patients with a high risk of transformation, like, for example, the high-risk patients? This is an unsolved problem, but it's further complicated now by the possibility that we have another goal to be achieved in CML, which is represented by TFR, or treatment-free remission, that after a certain period of time really represent a cure of the disease. For a younger population, of course, we needed to have a cure for CML, not only an overall survival good, but with CML for the rest of their life. And certainly, I would say, how can we identify the patients who are at risk of progression? We have already seen the LTS score, which is very, very good on this task, but we have to consider also cytogenetic analysis. And therefore, it's imperative just to perform cytogenetic analysis and diagnosis, to see if there are additional chromosomal abnormalities. This is a list of the chromosomal abnormalities that we have to look for, because these high-risk chromosomal abnormalities are associated with, I would say, a diagnosis which is definitely different, with a survival approximately 50% if they are found in diagnosis with respect to those without additional cytogenetic or with the low risk additional cytogenetic abnormalities. I would say that in the high risk are almost the most frequent. So if you have abnormal cytogenetic abnormalities, additional cytogenetic abnormalities, please be careful and monitor carefully the patients. Another point is coming by the fact that we know that if we do not apply an inhibition of the BCR-ABL tyrosine kinase activity, we have a progression, evolution, and rapid evolution of the pH-positive clone. So we need, if possible, to perform an early diagnosis before the other subclones and the effect of the oncogenic potential of the BCR-ABL tyrosine kinases are generated, finally leading to the progression of the disease. And this means that the early blast crises that we are observing in our patients are due to the fact that we have already subclones, we are transformed in diagnosis. We do not see them because they are, of course, submerged, we can see, by the other clones, by the main clones, but they are already present, and so after applying TKI therapy, these resistance are coming out immediately as blastic transformation. But we have to consider also that also normal typoiesis in CML is not always so normal, we can say. It can be more or less hosting some clonal hematopoiesis, the famous CHIP, and some of these clonal expansions are, that we can see with NGS and other methodologies have oncogenic potentials. Among them, I would say the SLX1 is particularly important in CML. It has been endowed with the possibility to confer an inferior outcome in terms of failure-free survival, as you may see, and also is associated, and this is being confirmed also by some other data, more recently presented at ASH, is associated with a high rate of mutations. So it's something which favors indeed the mutation. We say that XLX1 mutations can be present in, according to different studies, 20, 25, 30% of the population studies diagnosis of CML. So by putting all together all these aspects, we can probably even better identify the patients who have a high risk of transformation. What to do for these patients? At the moment, of course, we have to monitor them closely, but of course we need also to think of more effective therapies, which cannot be represented simply by second generation TKI, but maybe by other approaches that we are studying at the moment. Concerning the first line therapy, as you know, and this will remain the same, the European Leukemia Net guidelines do not make a precise choice because no TKI is recommended over the others, and generic imatinib is the most cost-effective option. This was true, but now also the second generation TKIs, dasatinib, nilotinib also, and bosutinib too, are becoming generic. So the gap or the expenses of the difference in cost is not so high to justify choice based on this. But certainly second generation TKI have a higher potential to achieve a faster and deeper molecular response, as shown in the NEST-ND trial with the nilotinib. As you may see that this occurs, there is this divergent curve within the first 5 years from the start of the therapy, but then the two curves remain almost are going in parallel, and certainly there is I would say, a decrease. And what does it mean from a practical point of view? That if we do not achieve within 5 years a deeper molecular response, in this case MR4.5, which is the level of minimal residual disease that we expect to try after a while to try to stop therapy, it's difficult to have it later on. And therefore, these are the criteria established by health. And we know that with time, nilotinib is causing, indeed, also an increase of the risk of cardiovascular events. So if we are starting with the present second-generation TKIs, both nilotinib and dasatinib, which are definitely more toxic, it's better not to prolong this therapy for more than 5 years. And if after 5 years the level of residual disease is approximately, is not reached MR 4.5, maybe we can decrease the dosage, for example, to a maintenance dosage, or we can go back to the old therapy like imatinib and so on, which is definitely less toxic. Of course, however, the fact that they are inducing a faster and deeper molecular response is also determining the fact that more patients are achieving the condition to try to stop therapy, and therefore this is the slide. And so this is why I think most of the younger patients, at least in Italy, are treated with second-generation TKI. What we have learned about the TFR in the last 14 years is possible, is a cure, is trying to achieve is substantially safe, not higher risk of progression with respect to what is observed in patients, patients in which are continuing the TKI therapy. Very, very few cases, very rare. We needed to achieve a stable, deep molecular response and to keep it for a certain period of time. How long? This is difficult. We've established arbitrary points of duration, but we do not know really. The patients, this is very important from the psychological point of view for the patients, failed that the first TFR attempt can be rechallenged after achieving again deep molecular role for 2 years with less but still chances to achieve TFR. There were recent publications about this. One is the stop to trial, which, as you may see, is 50% of treatment-free remission after the second attempt. And this is another trial, which is the continuation of the French NILO post-STEAM study, which means that after relapsing, after discontinuation of the therapy with imatinib, the patients have been treated with nilotinib. After 2 years, they have stopped. And you may see that months since the nilotinib cessation is approximately something around 40%. So little bit less with respect to the first attempt, but still possible. So it means that you can say to your patient, we can try now, but if we are not successful, we can retry in 2-3 years time, and we will see what's happened. Sooner or later, we will win. However, the rate of patients who are achieving TFR at the moment is still limited, probably 20-25% of all the similar patients, and our goal is just to improve this percentage, in part because patients are not attempting, even those who are really in the condition to try to stop TKI, they are not stopping TKI for several reasons. Because the parameters now to decide to stop TKI are quite rigid at the moment, not so friendly. And we can say all the parameters that we have seen before are completely valid. Is the TKI potency important? Is the degree of the depth of molecular response important? Is the duration of the TKI therapy or the duration of the deep molecular response more important? Certainly second generation TKI, and these are quite late data, have a little bit better in inducing also higher rate of successful TFR. This difference is not statistically significant, but there is a trend, and more data now are pushing the fact that probably are more effective, even if the observation time are not perfectly comparable between this group. So certainly we can say the second generation TKI induce faster and deeper molecular response than imatinib as frontline therapy or as an early switching non-optimal responders. Frontline therapy for patients of which TFR represents the goal of therapy. And now I would like later to discuss with you, are you speaking about the TFR when you first see SML patients or not? This is an important point that we have, because of course we have to talk also about the toxicity. But now the toxicity of the second generation TKI may be limited by the fact that we are reducing the first line dosage of the TKI. This is an important study published already 2-3 years ago by the MD Anderson, showing that even 50 milligrams of dasatinib instead of the classical dosage of 100 milligram are able to induce very deep molecular responses in a rather short period of time, even higher with respect to the 100 milligram, probably because this dosage is better tolerated by patients and apparently safer, in the sense that there are still episodes of pleural effusion, but definitely the rate is lower with respect to the others. And now the other point to consider, is it possible to discontinue the TKI therapy when the patient is more than, I would say, first-line treatment, is on second and third-line treatment? And there is this important study, which is data collected by Frank Nicolini and by Carmen Fava, with this trial, Ponastop, Italy Free TFR Registry. If you want, you can join it if you have cases like this, in which they have seen that patients who achieved a very deep molecular response with ponatinib, and this is a very important point in my opinion, have the possibility to remain in TFR with a high percentage of probabilities of remaining in TFR, approximately in 2/3 of all cases. And this is very important because for many years we have asked if a patient is responding well to ponatinib as first-line therapy, as a third-line therapy, should I continue ponatinib for the rest of his life or may try sooner or later to discontinue? And this is the answer. It's possible also to discontinue with ponatinib, avoiding all the side effects that ponatinib is bringing with him. So another point is the molecular response. Molecular probably has been the importance of the molecular monitoring has been a little bit exaggerated from my point of view, but in this case, for deep molecular response is extremely important. These are data from Iab Abdullah and Abdallah, and you may see patients who are using droplet digital PCR, which is a very sensitive method. It's quite easy, however, to apply that to our patients who are negative. You may see the much better treatment-free. We are approaching approximately 80% of the cases with respect to remain positive. If we combine the two together, you may see that those who are RQ-PCR, traditional RQ-PCR, droplet digital PCR undetectable, have a risk of relapse of the disease which is approximately 10%. Another way that in which we have to approach, in particular to decrease the rate of molecular monitoring requested after discontinuation, is certainly just to decrease the dosage of the TKI little by little, as it has been done in the study with the famous Destiny trial. And now what we are trying to do in Italy with this Dante study, which patients treated with nilotinib have been decreased and maintained for the half of the dosage, 300 milligram once a day for 1 year. And those who were not losing MR4.5 with sustained DFR, indeed had a discontinuation rate which was again 70%, so 2/3 of the patients. And this is good because if we are going little by little down, this of course is requesting less intensive molecular monitoring, less stressful for the doctors and for the patients, and so less rate or risk of being unsatisfied for the TFR results of the first instance. It's still an elusive phenomenon, we have to understand it, but we have a very good place, asciminib. I do not have time to develop about this. First line asciminib is giving better results with respect to TKI investigator choice. And this is done by the fact that the patients who are discontinuing therapy are definitely less with respect to our discontinuing both imatinib and second generation TKIs. But this is an important, very important aspect to consider. that with respect to second generation TKIs, you may see that it seems particularly there is an advantage in the high intermediate risk group, and particularly for elderly patients, which means that this drug is really effective and very well tolerated. That's what we want. So although certainly is a drug that will be unfortunately quite expensive, and therefore what we say will have certainly economic toxicity. However, I would say that for a specific subgroup of patients, so let's think of women who wanted to become pregnant and so on, who have the urgent need to achieve a TFR or to be in a very deep molecular response, this could be a good choice. So for a specific subgroup of patients could be a good choice. The median time to molecular response is lower. And the final point that I want to touch, because I'm going out with time, I never calculate, this is the old table, still valid of course, and Ilmer after me will present this, where we have to change therapy according to the referral rule. But also this table is challenged by this paper published by Rüdiger Hellmann 1 year ago, 2 years ago, saying that indeed all patients who are not matching the European Leukemia Net guidelines have an overall survival which is not so dramatic, unless that they do not reach 10% after 2 years or so on. So what is it? This is the table, and this will be matter of discussion at the end of February within the European Leukemia Net group. So there will be a high failure risk, particularly in patients. So we are changing the definition, not failure, but high failure risk, particularly for those that after 1 year of therapy are still above 10%. This is already something which is quite logical. And in particular for those who are later previous, so loss of previous responses. Why this? Because it has been demonstrated that patients who have not achieved, for example, the milestones within 2 years will achieve in 2/3 of the cases the milestones after additional 2 years. So we have late responders. And the study of the mutations and so on is particularly important for patients who are losing the response, not the patients who are continuing to respond. I must say that this was the definition already done by a person that I consider very clever, who is Abu Kantarjan, and at least 4 or 5 years ago. Thank you very much for your attention. Please remember, okay, we have still another drug coming, but we have not time. Thank you very much.
Thank you very much, Beppe, for this nice presentation. We're a little bit over time. Yes, we can take a question. Dr. Burhan Ferhanoğlu.
Thank you very much for a nice presentation. I have really several questions. First, all of the comparison data do not show any advantage of second generation TKIs when they compare with imatinib. How do you explain the data of Italian, real life data, which there is overall survival difference?
Yes, I would say that no study, with the one exception, which was in the NSND, the patients who were treated with imatinib versus nilotinib, but 400 twice a day, was showing a statistical difference in terms of, but only there was a numerical difference as we observed. So we will say that second generation TKI is not definitely so the choice of second generation TKI to avoid early progression is not suppagated by the data. And you know that these are real world data, whereas in clinical studies, sometimes for several reasons, we avoided to include on all patients that we observe. We avoided to include patients who cannot come to the follow-up, who so have difficulties. So clinical studies are extremely important, randomized studies are extremely important, but real-life observation is even more important to test if those things which are coming from the clinical studies are valid or not. Because however in clinical studies there is always little bit bias of selection of the patients, which are definitely the better and best one as well. So I think that it is important that these data are collected all together and we can see which is the real effect. What I can say is that we needed to be more relaxed in treating CML. We must be prepared to treat advanced phase CMS. This is a big problem once that this occurs, and to pay particular attention for the high-risk patients, which are only 10%, at least in the Italian population, but maybe higher in other populations, I would say, because, and so just to see that what is extremely important is particularly is just that the patient is really compliant to the therapy. For all the TKIs, also the old, we can say, imatinib are good on this purpose. If we want to achieve TFR, it's a different problem. This is my thinking about it.
Thank you very much.
Okay, thank you.
My second question regarding your last proposals, which changed the third month, 6 months results and recommending to be relaxed actually. I wonder whether for such as imatinib, which we can achieve late response, for example, in 1 year, MMRI, etc. Whether can it be any blastic or accelerated phase transformation between 9 to 12 months?
Of course, this is a protocol, so all the protocol just fixed rules and so on. But the idea that we are using some TKIs, particularly second generation TKI, that higher dosage than needed is becoming very, very popular. Almost our patients were already in 300 milligram of nilotinib only per day, and so they were persisting in this state. So I think that dasatinib 50 milligram is going this direction. So do we have to continue the full dosage for a certain period of time, or once that we achieve a goal, we can try is very to decrease the dosage and so on. This at the moment is difficult to say. It's something that probably needed to be tested in clinical trials and so on. But I think that we know that if there is certainly, I would say, again, an increase of loss of response, because this is, I would say, just a trigger to see, by decreasing the dosage, to see if there are mutations, because mutations can be sensitive to the amount of dosage that we see, and to restart the full dosage. So to manage the patients in a more flexible way, I would say, to see. But definitely the goal is overall survival first. But certainly TFR will be the goal of the future, because we cannot continue to have, it's 25 years that we are using now imatinib. We are observing some long-term toxicities already, and for younger patients this is not good. So there is an evolution that we have to take into account.
My last question regarding 49 years old female with CML history of 15 years. She has already received imatinib, not very well adherence to imatinib, then quit dasatinib due to side effect, and she achieved after 1 year major four-log molecular response to asciminib. In 1 year, her response decreased to 3 logs from 4 logs. What is your recommendation for such a interesting?
Asciminib, surprisingly, I didn't present the slides, but for some group of CML patients is extremely sensitive. There is a group of patients who were not achieving exactly your, there is a trial concerning this, which is called ask for more. And indeed, there is a rapid drop. So there is a group of CML patients that we do not know, but I suspect to be also presenting first-line therapy, which are extremely sensitive to the action of asciminib. This means that asciminib is selective for BCR-ABL, so that all the, I would say, what the evolution of the disease is due to the activity of the BCR-ABL tyrosine kinase. If we block this, everything goes down. Whereas using the other TKIs, you are also inhibiting other tyrosine kinases, and probably this balance can be advantageous in some cases, as in this case, but maybe disadvantageous in other cases. I think that the future of the TKI therapy will be a combination of drugs like asciminib, because asciminib is already registered now as third-line therapy, is available in the United States as first-line therapy too. But there are other drugs coming out, like a Chinese drug and so on. So in the future we will have many drugs that probably will compete also in terms of cost and so on, just to be combined with traditional TKIs inhibiting the ATP binding pocket and with this ministerial pocket drug. So this probably can be the future, and the combination trial will probably, it's difficult maybe because there is a little bit more toxicity, but probably will be very effective in eradicating the disease.